Q&A session. Let's start a recording, and we are going to be sharing it with those who registered and were not able to join at this time. I'll press OK. Next, I would like to make note that of those who are joining as a group and did not register using your own email address, we will share a link in the chat where you can sign up as an individual to receive future emails from us as well. I am now going to introduce our panelists. First up, we have Tami DeAngelis, who is a geriatric physical therapist and owner of DeAngelis Physical Therapy and Wellness in Concord, Massachusetts. Tami, why don't you wave to everybody? Next, we have Rosa Pena, who is Vice President of Programs and Services at APDA and a licensed social worker. And Rosa is there, right? In my center of my screen. Lisa Sommers is a speech and language pathologist and clinical associate professor of speech, language, and hearing sciences at the University of Massachusetts in Amherst. And there's Lisa, thank you. Giselle Tamula is a certified nurse practitioner at the Pacific Movement Disorder Center in Santa Monica, California. There's Giselle, I want to wave, thank you. And Kathy Thomas is a clinical nurse specialist, assistant professor of neurology, and program director of the Parkinson Disease and Movement Disorder Center at the Boston University Medical Campus in Boston, Massachusetts. So that, and there's Kathy, thank you. So welcome to all our panelists. We're going to start by giving a brief overview of the material in the online course, and then we're going to jump straight into questions. We have received questions via our registration link, so we do have those, but you can, of course, ask your additional questions, putting them into the chat as we go through our Q&A, and we're going to try to answer as many as we can. So we're going to begin with the review of the online course. So this review is going to briefly cover the motor and non-motor problems associated with advanced Parkinson's, the gait and balance challenges, the problems with speech and swallow, treatment options, and the psychosocial struggles of people with advanced Parkinson's and their families and care partners. We're only going to touch on the highlights of the course because we do want to spend most of our time on the Q&A. So we are going to begin now. I'm going to share my screen. And hopefully you are able to see that first slide. Do we have a thumbs up? Fantastic. Okay, so here is the lineup. We are going to start with some key motor symptoms. We'll talk about motor symptoms in advanced Parkinson's specifically, some key non-motor symptoms, difficulty with communication and swallowing, a little bit about treatment, and a little bit about recognizing the needs of the care partner and family. So Kathy, would you begin for us?
Yes, and thank you, Dr. Gilbert, and thank you all for joining us with this program. So I just want to provide a very brief overview of what Parkinson's disease is, and it is a progressive disorder of the nervous system. And it is slowly progressive, although from individual to individual, there can be some differences. But because of the symptoms that a person has, Parkinson's disease can often affect a person's ability to perform daily activities. And I'll just briefly mention the motor symptoms. A person with Parkinson's has both motor symptoms, actually resulting in how we move, as well as non-motor symptoms. I'll talk a little bit about the motor symptoms, and then you'll hear from one of our other presenters about non-motor symptoms. So the key motor symptoms are tremor, and tremor typically in Parkinson's occurs at rest. It can be quite variable from person to person, and some people with a diagnosis may not have tremor. Some people don't have a tremor that's visible. They experience an internal tremor, and oftentimes a person will share that with you. The other major motor symptom is slowness of movement, and everybody with a diagnosis of Parkinson's has this particular symptom. And really, it's how fast a person is able to move, whether it's an extremity or, fine motor movements. Slowness of movement oftentimes is thought of by many as the most disabling symptom. And then the third major motor symptom is muscle rigidity or stiffness, and this can occur in all extremities and to varying degrees. When Parkinson's is first diagnosed, a person may have it simply on one side of the body, and as the disease progresses, you'll see symptoms on both sides. And then the fourth symptom, gait and balance disturbance, our physical therapist will address that. So just my key takeaway, it's a progressive disorder. Today we will really talk about some of the advanced symptoms of Parkinson's disease. Okay.
All right. So I'm just going to briefly mention some of the key parts of the course that that were discussed in my section. There are some great videos there. So again, as Rebecca said, if you haven't gone and seen this, it'll make what I'm about to say will make a lot more sense with some of the supporting videos. But we just briefly talk about freezing of gait. It's the tendency for the feet to get stuck. It can start with a lot of little steps and then actually be a full freeze. And there's different triggers to freezing. So it can be distractions or a problem with attention. So visual distractions, even just the person with Parkinson's thinking about something else while they're trying to walk at the same time can be enough to trigger a freeze. There's environmental distractions. So thresholds, or even clutter in the environment, or a small environment can trigger the freeze. And then particular movements that tend to be hard, and those are initiation of movement, but also turning are the two movements that tend to trigger freezing. And as people helping people with Parkinson's, I think one of the most important thing about these issues with freezing is that they really high incidence of falls with people who are freezing. So thinking about different ways to transfer, to get from the bed to a wheelchair if they're using a wheelchair, get from one room to another with a walker, and managing freezing and minimizing fall risk. So devices and transfer devices and grab bars and all those things are critical to keep the person with Parkinson's, whether they're a freezer or not, often safe. And then, so fall prevention is key. We also, considerations about as the disease progresses and you're in a prolonged position for amount of time, and often, pretty significant stiffness and rigidity is part of the clinical picture. We think about positioning in the bed to reduce, both shortening of the muscles, but also pressure ulcers and things like that. And then lastly, the exercise and movement at any stage is critical, and finding, what a person can do. And those assisting people at home are such a huge part of the person with Parkinson's being able to exercise throughout the disease course. Because as many people know, physical therapy comes and then they are out and that, they come a couple times a week for a certain amount of time, but it's often the caregivers at home who are the ones maintaining the mobility of the person through those programs. So thank you. I will pass it on next to Giselle, I believe.
Thank you very much. So when we talk about Parkinson's disease, much of the discussion is on motor symptoms of the Parkinson's because it is a movement disorder after all. Yet as the disease progresses, the non-motor symptoms may actually be more challenging than the non-motor symptoms of Parkinson's. So here we just want to review some of the non-motor symptoms of the Parkinson's. So they can include problems with mood, such as depression, anxiety, and apathy. And sometimes this can be really debilitating for the person with Parkinson's and actually exacerbate their symptoms of Parkinson's, their motor symptoms of Parkinson's. It could also be problems with thinking and behavior. It could be increase in irritability and sometimes difficulty with focusing and attention. It could also be, as the disease progresses, increase in hallucinations and delusions. What we have known from the course is that, hallucinations are false sensory perceptions where the person with Parkinson's may hear something that isn't there, or see something that isn't there, or sometimes they would feel like a presence in the room that actually isn't there. It could also be delusions where there is a strong held belief, it is a false belief, that is very difficult for the person with Parkinson's to be convinced otherwise, even if there is evidence to the contrary. Sleep disorders can likewise happen, and this could include insomnia. It could be REM sleep behavior disorders where you could be experiencing kicking, punching, screaming while they're asleep. It could also be just somnolence during the day or daytime sleepiness as well. Another thing that can be experienced by people with Parkinson's are drops in blood pressure that can lead to them falling or passing out. This is pretty common, and it could happen. We call it orthostatic hypotension, where the blood pressure, especially the systolic blood pressure, can drop 20 points or more. There could also be some difficulty with bowel and bladder, including constipation, which is a very common non-motor symptom of Parkinson's, and urinary incontinence. This could be very challenging to manage for Parkinson's patients and cause them a lot of discomfort. Next slide.
Thanks, Giselle. I'm Lisa, and I'm from speech language pathology. And I think I come at a place that really my slide pulls together these motor and non-motor symptoms really come into play with people who have advanced PD and who start to experience difficulties with both communication and swallowing. So as the disease progresses, one very common feature is that the voice becomes very soft and speech becomes very imprecise. People may decline to the point of being unable to really express themselves in a way that people can understand them at all. The APDA does have some really good resources that we'll put in the chat now that have to do with communication and swallowing changes, specifically in Parkinson's disease. So we'll put that in the chat so that you have that as a resource. But people also have declines in their processing and their thinking of words. This makes communication very difficult and frustrating on top of the motor problems that they have. Additionally, swallowing can become compromised. People often have unintended weight loss. It takes them a long time to eat. It is also changes in their reflexes and in the timing and the coordination of their swallowing, putting them at risk for aspiration. And so all of these interventions that we do as speech language pathologists kind of happen across the disease course. We'd like to start seeing people as soon as they're diagnosed, and we like to see people on interdisciplinary teams where we're all working together. And we continue to see people across the span of the disease process, and there's a lot we can do even at the advanced stages. So next I'm going to turn it over to the next person talking about medications. I think it's Rebecca.
Great, thank you. So I'm going to talk really briefly about medications. There are multiple medications that are available to help treat the symptoms that we have just heard about. And these symptoms primarily are focused on relieving the motor problems. And there is this phenomenon as symptoms are treated that a person may get relief from their symptoms for a brief period of time. And we call that the on time, where their symptoms are well treated, but that effect may not last a long time, and then they may actually veer into what we call off time, where their symptoms are not as well treated, and they may have these ups and downs during the day. That's also called motor fluctuations or on and off time. And it's important to know that as you're taking care of someone with Parkinson's, that they may have a lot of variability in their day. So please be aware of that, and please bring that to the attention of the neurologist when if you accompany your person with Parkinson's to their visit. Please share that information, because it could be very helpful to adjust the timing of the medication when somebody knows how the course of the day unfolds. There's also this phenomenon called dyskinesias, which are involuntary movements. And to say again what Tami said, we have videos of these in our course. So again, encouraging to take the course where you can actually see this unfold. Dyskinesias are involuntary movements that can be a side effect of medications. This can be acceptable. They can be movements that are not interfering with function, but they can become problematic as well. So that's something else for you to note. We have medications that are available for some non-motor symptoms, for symptoms like depression, certainly for constipation, to manage blood pressure. So all of the symptoms, the takeaway should be bring all that information when you go to the neurologist and discuss these motor and non-motor symptoms, so these medications can be adjusted. There are brain procedures besides medications that are available. Deep brain stimulation and focused ultrasound are two brain procedures that may help. And of course, without a doubt, physical occupation and speech therapy are crucial for managing advanced Parkinson's. So really a team effort as Parkinson's advances. And finally, I'll pass the baton to Rosa.
Hello, everyone. So caring for a person with advanced Parkinson's disease, it's really a journey that's filled with love, dedication, and sacrifice. And we also know that that journey can be very physically and emotionally exhausting for care partners and caregivers. So sometimes, the families experience daily challenges, from managing medications to mobility issues to navigating changes in communication and cognition. So that weight of responsibility sometimes can lead to stress, fatigue, and even burnout. So we do know that about 40 to 60% of PD caregivers can experience depression and anxiety as the disease progresses. And so we know that they don't have to do this alone, that APDA is here to recognize that the loved one needs care as well. And through this journey, we're here to assist and help and provide support. So we have a vast array of resources, programs that can help the families through this process. We have educational resources through our information and referral centers, our chapters, and our 1-800 helpline. And these are, materials that we can send to the home, virtual programs, our blog posts, just so many information. Support groups that are dedicated for the person with Parkinson's, for the care partners, for adult children of someone, that are living with Parkinson's. And so these are dedicated support groups. Many are facilitated by professional facilitators, healthcare providers that can help in this journey. We have respite and wellness programs. And so caring for someone with Parkinson's is a role of strength and compassion. But no one, again, is meant to do this alone. And APDA is here to support, guide, and empower the families so that they feel supported and they can continue to care for their loved ones. So thank you.
Thank you so much, everyone. Fantastic. So I'm going to stop sharing right now and go back to our expert panel. And now is really what everyone is here for, which is our Q&A session. So please feel free as we address the questions that have already been asked during registration. Please feel free to put additional questions in the chat, or just listen to our answers, whatever you feel most comfortable with. So we're going to start with a question that came in through registration, and I'm going to give this question to Cathi. So somebody asked as they registered for more information on something called neurogenic orthostatic hypotension, which Giselle mentions is one of the non-motor symptoms of Parkinson's, which is this drop in blood pressure that can happen commonly as somebody who has Parkinson's disease. So Cathi, would you address what it is and some tips and tricks to help manage low blood pressure in Parkinson's?
Yeah, so thank you. And thank you, Giselle, for introducing this. So neurogenic orthostatic hypotension is actually failure of the autonomic nervous system to regulate a person's blood pressure. And we see that in Parkinson's disease. Like I always say, not everyone has this symptom, but if you do, careful attention needs to be observed. And this is a symptom that actually, as the disease progresses may be more evident. And it happens when a person changes their posture. So it could be as simple as getting up from lying down to sitting on the side of the bed and then standing up. A person's blood pressure may decrease. And people sometimes share that they feel not well, they feel dizzy or lightheaded, and alternatively, some people don't even realize that it's happening. So as healthcare providers, we want to be very careful to assess whether it's happening in our patients, and as you at home or as a care provider, the same thing. So just some things to do about this condition. First and foremost, a person needs to be safe. So if they do experience this problem, you always want them in a safe environment. So if your blood pressure drops when you change position, you could, you could feel faint. You could, actually faint. So you want to make sure a person, if they have this symptom, is not getting up out of bed by themselves, or maybe being in the bathroom in the morning unattended if they feel lightheaded. So safety first. And then we also want to educate the person with Parkinson's, the family members, the caregiver team, anyone that actually is with a person who could experience this. So safety and education. And then there are things that the healthcare provider, the doctor, can prescribe. And one thing that's very important is to increase hydration or our water intake, so not to be dehydrated. Very hard to do in Parkinson's because people avoid drinking water, but it's very, very important. Sometimes their salt intake may be increased, and this is with the guidance of their healthcare team. Other things that can be done using compression stockings or an abdominal binder. One thing that's interesting with people that have this condition is when they lie in bed, oftentimes their blood pressure can actually be higher. So even having the bed elevated, 30 degrees can be quite helpful for people. And then one thing I always encourage is that people monitor their blood pressure, particularly if the doctor has prescribed some treatment for this. And if you're if you're providing care and doing blood pressures, we encourage you to do a sitting blood pressure and a standing blood pressure, maybe once a day, depending on the person's regime and how closely they're being monitored. And then you can sometimes see that. And also encourage slow transfer. It's amazing. People will get up quickly out of bed or change position out of the chair. So do things slowly. So those are some of the tips that we find helpful.
Great, thank you so much. So we have a question. There are no silly questions. Maybe Giselle, you take this. Would an IV help if someone's not drinking enough water and they have this problem? Would you consider an IV hydration?
You could, but that's a little bit more extreme too, and might not be readily available for most people at home too. So I think one of the easiest things that you can do, one of the things that I really tell patients if they're experiencing a lot of this lightheadedness, just to go back to Kathy's tips too, is drink water. If you have some sort of electrolytes like IV hydration or IV hydration, although this is a powder, for those that don't know, you could add it to water. And another simple thing that you can do is I tell patients to snack with something salty too. And that could be maybe salted nuts instead of unsalted ones. It's an easy way to get your blood pressure a little bit higher too. So that could be something that could be easy to do at home or in a facility too. I also just want to add on the safety, because definitely, we do encourage you to go slow, transfer slowly, but also recognize that sometimes this lightheadedness doesn't really immediately happen. A lot of times this could happen 1 to 2 minutes after you stand up. So that is sometimes good to know for people caring for Parkinson's patients, that it doesn't usually happen immediately when you stand up, but it could happen 1 to 2 minutes after. So recognize that if you get up and maybe go to the bathroom, take a little bit of time and stay closer to maybe the wall or something that you can hold on to, because sometimes the drop in the blood pressure is going to take a little bit of time.
Great, thank you so much. So we have a question that came in, a kind of related question from Nadine. When a client rapidly declines, becomes completely non-weight bearing, frequent dyskinesias, difficulty swallowing, is this an indication of poor compliance with medications or side effect of medications? I'm happy to take that one. So first and foremost, when there's a rapid decline in Parkinson's, our minds first go to, is there another medical problem going on? We don't really attribute rapid decline to Parkinson's advancing quickly. That doesn't really happen. Parkinson's advances very slowly over the course of at least months or years. And so if somebody's like doing okay and then they end up in this situation where they can't get out of bed, we want to look for something that may have just happened, and very frequently it's a urinary tract infection. So our go-to would be get this person's urine checked and some basic bloods to make sure there isn't anything going on. If it's when you say rapid decline, you don't mean like in a few days, but sort of over months to a year, you're getting sort of this declining situation where you're very become much more dependent, and there could be frequent dyskinesias and difficulty swallowing. What else could you consider that isn't that could be reversible, I think is what Nadine's getting at. And certainly you would want to think about medications. Could medications be pulled back a little bit? A lot of dyskinesias are a side effect of medications. And so if you're having a lot of dyskinesias, it could be that there's too much medication on board, and pulling back a little could be helpful. If somebody has a lot of dyskinesias, that could trigger a lot of weight loss. They're moving a lot. They can't keep up with their calorie count. And so that can go together. So pulling back on some medications can be useful. If somebody's lost weight but is on the same amount of medication, that may be too much. So certainly evaluating medications when this situation happens would be really important. Again, there could be, and I'm going to ask Lisa to jump in as well after just I say one more comment. This could all be triggered by difficulty swallowing. If somebody has difficulty swallowing and then they lose weight because of that, then that can trigger a whole series of badness that could be prevented by really addressing the swallow. So Lisa, why don't you take it from there?
Yeah, I think it's really important to follow up on even subtle changes in swallowing, because it can be a precursor to, sort of this effect of one thing affecting another. One thing I will say is there aren't a lot of medications that directly target swallowing, and that through line of meds directly affecting swallowing is not there. So swallowing and speech do not really respond to any kind of pharmaceutical sorts of intervention. So it's really important to follow up and figure out what's going on. And hopefully that has kind of helped to answer that question. And while I'm here, I see that there's a question about a dry cough. So I'm just going to jump right in and follow up on that one too, because they're all kind of interrelated. I wouldn't ignore coughs either. And even if it's not related, sometimes it's randomly at a meal and sometimes it's otherwise. One of the things that I find a lot of patients do is they clear their throat or they cough in order to get their voice started, because they're already having changes in the way that their vocal folds are working because of the Parkinson's disease. And cough or throat clear is a way that they kind of jumpstart, and it becomes a habit. And so sometimes you see those kinds of things happening as well. So really getting on it and getting going with swallowing is really important. And it's also an interdisciplinary thing. So again, other therapies would be involved as well, not just speech language pathology services.
Fantastic. Thank you so much. We have a question about penmanship. I wonder, Tami, would you be good jumping in there? What does it mean when a person writes very small? That
Yeah.
seems like a random symptom. Go for it.
I know. Well, it's all part of that. So it's called micrographia, but it's all part of that decreasing in amplitude. So small, smaller voice production, right? Not as loud, smaller steps, just smaller movement altogether. So that it's often an early symptom. And it can be tricky. There are definitely tricks that you can use, trying different pens that don't have as much reliance on the angle of the pen can often get a better ink flow and allow for an easier time with writing. You can also try to, just as when we say bigger steps or step to a laser or step to a piece of tape, you can use that same strategy to increase the amplitude of the writing or the penmanship by using lined paper or using paper with really distinct far apart lines, and cue the person to go back and forth. And I'll tell you, with all these tricks, it's one of those things that can be pretty frustrating for people. So you can try the tricks, but then, and Lisa can speak to this, but the voice, sort of voice activated softwares now are so much better at dictating voice. So sometimes it's a matter of finding assistive technology to be able to communicate, and where you once might have written, you could do voice dictation. But Lisa, do you want to add anything to that?
Yeah, it's a complicated issue because so often they have a soft voice, and then the systems that you would use to go from voice to text often can't hear them or can't understand them, especially with advanced Parkinson's. And so it becomes a little bit of an issue, for sure, if people are still wanting to write. So I think it's trying a number of things. Working maybe with occupational therapy sometimes can be helpful for people. So yeah, I think it's worth trying, but it is a frustrating symptom that people encounter for sure.
Great, thank you so much. We have a question from Erica on hallucinations. So Erica's husband has hallucination, working closely to try to help. Any thoughts on this? I'm going to ask Rosa. Would you be able to comment on how to deal with hallucinations? Maybe not from a changing medications perspective, which we can get to as well, but from how do you deal with someone who's hallucinating?
That's a really difficult one, because what we find sometimes is that the family members want the person to live in their reality at the moment. So if they're having a hallucination, they'll say, well, that's not really happening, or, what are you talking about? Or, and so that could be perceived even more as a pushback from the person experiencing the hallucination. So that can make them more upset. It can make them double down on, but I'm seeing this, I'm seeing a person standing there. So I think the best way to approach it is to stay calm, to understand what is happening, to kind of guide the person and redirect them to something else. Maybe, let's watch a little bit of TV, or let's take a walk, and let that pass. And then certainly speak to the physician, to their doctor, and see, how they can be evaluated further, if there's any medications that can help as well. But knowing that this could be part of the disease progressing, and it's really about providing the support to the caregivers and the family members, because they themselves may need to bring in someone else when those things happen, when those situations happen, so that they themselves don't become reactive and stressed, because that will stress the person with Parkinson's more. So really, it's not trying to rationalize and help them understand, because they're not going to be able to understand it in the moment that this is happening. So that's for the care partners. So really just learning about it, educating themselves, getting support so that they don't feel that this is just happening to them. And I think that's what happens many times, is that the family members, the caregivers, feel that they're alone in all this, and that isolation just makes those situations worse.
Thank you so much, Rosa.
Can I add a little insight too on the hallucinations? I just wanted to add too that a lot of people, about 50% of patients that do have Parkinson's can have hallucinations, and it doesn't necessarily have to be treated. A lot of these patients, especially initially, can have hallucinations, but they do have insight into it, and they are not scared, they're not terrified of it. So we usually just monitor this hallucinations. If it is certainly happening more frequently, or patients lose sight with reality and it becomes something that is very terrifying for them, then definitely bring this to the attention of your healthcare provider so they can review medications and maybe recommend some medications as well. But I do agree with Rosa to really speak calmly to the patient, because I think that also transfers to them if they see that you're calm, and definitely not engaging the facts. Stop focusing on the facts that this isn't real. Instead, focus on the emotion that the person is feeling, that they're terrified of the hallucinations because they believe it is real. So sometimes distractibility can be helpful. And this could look like, hey, do you want to look at old photos, for example? Or maybe, hey, do you want to listen to music, your favorite music? And that sometimes can be very helpful to patients too. Or maybe just playing like a calm music, that could be helpful too.
Great. Thank you so much to both of you. We have a question that I want to address, which is my husband was diagnosed about 6 months ago, tremor, cough, small writing, not much more. It's difficult to deal with, wondering how and when this will progress and what to do in the meantime. So I do want to highlight that this discussion is very specifically about taking care of people with advanced Parkinson's. And that is a defined state that is not Parkinson's when Parkinson's is initially diagnosed. Parkinson's is a very long disease. It can take decades to unfold, and not everybody reaches advanced stages of advanced Parkinson's at all. Some people have mild symptoms and go about their business for many decades with mild symptoms. And so I do want to highlight that this course is really aimed at a very specific segment of people with Parkinson's. So somebody who may be tuning in, whose loved one has just diagnosed as mild symptoms, maybe has mild symptoms for many years, that's great. That's who you are. And many of the things we're talking about may not have relevance to you. So I do want to make sure that that's clear. We, of course, understand the anxiety of not knowing. The not knowing is truly scary in and of itself. And perhaps, Rosa, you can address that piece of this question of how, you don't know what's coming, you don't know what the future holds. How do you deal with that?
So certainly that's difficult to deal with, the uncertainty and the fear of that. And I think what has helped at some families is understanding, we don't know if or when that's going to happen. And so, as you said, Rebecca, that it's a long process, in terms of symptoms, living with these symptoms. So I think it's really about getting that support for the families to learn and be connected with other people that are going through a similar situation, so that they understand that no one knows the future. So we can worry about it, but it's not going to change really, when these things are going to happen. So it's really learning about what they can do today, what they can plan on tomorrow, for this week, and really living in the moment, because I think living in the future just creates more anxiety for people. Certainly being prepared is important. Knowing I have a plan. If this were to happen, these are some of my options. Those are always important things to know and learn, but really living in the moment. What can I do for myself as a caregiver? as a family member? And how can I help my loved one who's living with Parkinson's? And really, that's where the focus should be. And I think it's redirecting people to what you can do and what you have some control over and what can give you all a good quality of life. Because I think that's really important, that there's always, you know, a way to think about how we can make this better now. And that's hard because people want to worry, you know, the first thing is what can happen worse. But there's so many great moments that you can live with someone that's living with a chronic disease, and it's not forgetting to hold on to those moments. So it's reminding our families that we work with, it's let's think about the now. What can we do now? And I think that's helpful to many.
Thank you. Thank you very much. I'm going to ask Tami to address one of the questions that came in through registration. Presumably this was a person who asked a question who does a class for people with Parkinson's disease. And how do I convince my class to go at their own pace and to modify the exercises individually in the class instead of trying to keep up with others, which may be unsafe? How do you instruct the instructor if you have a variation of mobility issues within the class?
Yeah, this is an excellent question. And I read it and I was like, if someone knows the answer to it, I'd like to know also. But no, it's hard. And I lead classes for both people with Parkinson's and without. And it is a challenge. I generally go at, just for safety, I always go at sort of the lower level, have people hold on and keep a hand. I do balance classes in particular. And then I'll walk around the room, assuming it's in person, and I will say, hey, why don't you try doing this without holding on? So instead of offering a more challenging sort of version of an exercise to the entire group, I individually, after I get to know people, either talk to them after or say, you might want to try a more challenging, I can show you how to do that exercise more challenging. Because I have found, and it sounds like the person asking the question has also found, that if you present it to everybody, everybody wants to try the more challenging one. But that's how I handle it. I sort of tag people who I think could take a little more challenge.
That's great. Thank you so much. We have two questions that came in that are related that I'll take. Does medications hold the progression of the disease, and does medications help patients get better? And so I will answer both of those. So absolutely, medications help a person's symptoms in the moment to feel better and to feel more mobile. So you'll remember from our review in the beginning, what are the symptoms of Parkinson's? People tend to have slow movements, stiff movements. They may have tremor. They may have balance problems, walking problems. Those are the symptoms that are best targeted with our medications. And you can really have quite a good effect on people to the point that you may not even remember what they looked like when they didn't take medication. They may have a stoop. They may take tiny steps. They may shuffle. They may feel very imbalanced when they're walking. And the medications can help them really walk in a much safer way and to really have their movements more productive. The medications, however, do not, as far as we are aware, change the progression of the disease. And so if you remove that sort of band-aid about what the medications are doing, the disease progression is continuing underneath that. And so there is going to be that progression. We don't have a medication yet that can halt the progression. Having said that, there is a lot of research dedicated to finding that medication that not only changes symptoms, but also affects the disease itself and stops those nerve cells from dying in the brain, which is why the Parkinson's happens to begin with. So that there's active research. There's some molecules that are very promising that are in clinical trials now, but right now we do not have that medication. So we wanted to thank the two askers for those questions. Next, I'm going to ask a question that came in through the chat, and I'll ask this to Giselle. And this is a great question. How do you tell the difference between emotions or behavioral problems that may be attributable to Parkinson's disease versus maybe something else that's going on? Maybe they had TBI, maybe they had PTSD, maybe they had something else going on. How do you know that something that this person is doing, or some symptom that person had, is a Parkinson's symptom versus something else?
That's a very good question. And, there is definitely a lot of interplay for those emotions. And a lot of the base of those emotions is probably going to be anxiety, a high level of anxiety. But how I would probably differentiate it from Parkinson's versus TBI versus PTSD is that usually with the Parkinson's, it's more a mood. So we see a lot more depression, anxiety, even apathy with Parkinson's versus someone with PTSD may be more triggered by events. So it could be that they could have a little bit more intrusive memories. They could probably be a little bit more avoidant in their behaviors, while someone with a traumatic brain injury will have a little bit more difficulty probably regulating their emotions. So there probably is going to be more manifested through outbursts, anger and outbursts. It's probably how I would differentiate between those three.
Fantastic, thank you. Cathi, I'm going to ask you this question that came in through registration. Excellent, amazing question, which is how do we communicate the importance of Parkinson's medications taken on time to the healthcare community, specifically in nursing homes, in situations where the person doesn't have control over when they take their medications?
Yes, that is a question I've examined for many, many years. And it's certainly a real challenge for the person, the family, when a person is either hospitalized or has a different setting, a long-term care setting where somebody delivers medications. And it is, I think, probably some of the things being prepared, educated, understanding medications, developing a relationship with the team or the staff that is writing the orders and actually delivering the medications. So for example, in a long-term care setting where a number of people have to get medications on time, how can your loved one, or if you're a person with Parkinson's, receive the medications on time? And it takes education, letting the staff know that Parkinson medications need to be delivered on time, particularly your levodopa or medications that are timed. If you are going into a hospital, for example, for an acute event, sometimes you don't have that planning time, but you should still have planning at home, having a full list of your medicines, what time you take them. So if anything acute happens, you have that information to relay. And some of the things as a nurse I've observed is sometimes there's miscommunication. The healthcare provider doesn't even know that you are on Parkinson medications or that they have to be on time. So really, really being prepared, knowing what medicines you take, and then however you, depending on the situation, educating the staff, maybe at admission. There's one message I'd like to share with you. My husband needs to have his medications so that he can move easily. So we have not solved this problem. Two things: we have to educate people to understand this problem. So I thank all of you for joining this presentation today and taking the effort to learn about the importance of receiving how you receive medications, or how a Parkinson person does. We're coming up with strategies to do this, but good communication and preparedness are important. And I do want to mention there are some times, although rare, that a person can't take medicines. Perhaps they're having a procedure or they're unable to swallow medicines. And that's really a good time to bring your neurologist in, or whoever is prescribing your medications, to let them know, be aware of the situation. They can sometimes problem solve too.
Great. Thank you. And so hopefully, Cathi, talking to people on this on this Q&A now will help people realize
Absolutely.
how important it is to give those medications on time. It really can make such a huge difference to the people that you serve. So thank you so much for being here. We have a great question that came in through registration that I'll ask Rosa to answer, which is, what is the main thing I can do to help a client who has Parkinson's maintain their dignity and autonomy? What a good question.
What a good question. That really is. And I think it's one that we often think about as we talk to people that call us on the helpline, that come to our programs. How do you maintain that dignity and autonomy? I always think it's about encouraging independence. What I see sometimes is that struggle with their care partners where, well, they jump in, they want to, button their shirts, and the person gets frustrated. And I think it's about supporting them and maybe offering assistance and saying, you know, instead of saying, let me do that for you, to maybe say, would you like me to do that for you? Because then you're respecting the person's boundary and what they could do. And the other thing that we see sometimes is that the care partners are, they're thinking of the family members, they have to get 10 other things done. So they want to do things quickly and they want the person to move quickly and get things done. So it's really about allowing them additional time to do these small things that's going to take them longer to do, and being patient about that. And communicate with respect. So speaking, not speaking to them, but speaking with them. It's really about, having that conversation with respect, and then honoring their choices. If they want to wear something, as long as it's not offensive, or, if they want to wear it, let them wear it. What they want to eat, or how they want to spend their day. Maybe they're not having a great day and they want to just lay low and just sit around a little bit more that day. Instead of having total control of their activity every single day, to, let them preserve their sense of self, that they're still able to make certain decisions for themselves. And that's okay, because we all need that autonomy. And then, support their identity. So encourage activities that they could do, in interests that align, with who they are and their past passions, or what they like to do, whether it's art. Giselle talked about music, and we forget about the power of music for people. It really touches a different part of the brain. And so, we have a wonderful Connecting Through Art program. We forget about that. People become little children again. They love to connect and do these great activities. So really about those social connections, and remembering how important that part of our lives are for people with Parkinson's as well. As they progress, they may not be able to do, 20 things that they did before, but maybe they can still do 3 or 4. And just remembering that, they're not, they still have that sense of self. They preserve that part of who they are. So ultimately, really, it's simple. Treat them as a person first and a patient second. And that's the most powerful way, I think, about them maintaining their autonomy.
Fantastic. Thank you so much for that. We have a great question that I would like Lisa to answer. And this is about swallowing. I've been told to have my patients tuck their chin when they swallow. Is this the right thing to do?
Well, I'm really glad to field this question, because it's a real common myth that I've been trying to dispel for most of my career, it seems like. A lot of people are very tied to this as being kind of a one-size-fits-all strategy to help keep people swallowing safe. And it is something that for some people is a strategy that keeps them from aspirating. It actually is something that works and protects their airway, and it can be a very good thing. However, the only way we can tell whether or not this is a strategy that works is if we do an instrumental assessment, such as a modified barium swallow, where we have an X-ray. Because really, when you're tucking your chin, to see the effect of that, if I'm sitting beside you watching you eat, there's no way I can know what's actually happening in that area of the throat, and I don't have X-ray vision. And so really, the only time you should be doing a chin tuck with a patient is if the speech pathologist has done that sort of a test and can tell you that that is indeed one of the strategies that the patient needs. So that's a great question. I'm really glad to kind of get the word out to everybody.
Great, thank you so much. We are 4 minutes away from 2 o'clock, so we're going to try for one more question, see if we can maybe fit in 2. This is for Tami, such a common issue. My person with PD that I work with likes to be independent and will try to walk on his own when he shouldn't. What do I do? How can I get him to use a walker?
Yeah, so that is very difficult, and I deal with that every day with a lot of clients I work with. It's a challenge. I think it's because a fall can really change the course of someone's ability to, maintain being home, or obviously maintain safety and not sustain a hip fracture or something else. We tend to be pretty conservative when it comes to someone who's at high fall risk, not walking on their own. I think, making sure there's opportunities to get up and to move during the day in a safe way. And trying to find, all these themes that have come out today. So the social interaction, Rose has talked a lot about, enriching activities. So I think people are less likely to try to sort of get up on their own and do things when they are given opportunities to engage and do things in other ways, and they have a stimulating environment. They're on some sort of toileting schedule, so like they're not getting up because they don't want to have an episode of incontinence, things like that. So meeting all their other needs, I think, can help reduce that behavior of getting up when they shouldn't. But there's, of course, cognitive and insight issues that are going to lead to that. So it's a challenge. I hope that answered it.
Thank you very much. I think we'll again try for one more question, and Giselle, I'll have you address this one. My person with Parkinson's that I work with sleeps all day and is up at night. Any ideas to try to help with that?
It's pretty common to happen with Parkinson's patients where the sleep cycle has changed. So the best way to address it is really to change the cycle. That being said, it is challenging because sleep cycle takes, it's a habit that we built over time. So we definitely need to be patient in changing those habits. So some of the more practical things that you can do is stick on a sleep schedule at night, stay on that same time during the night. Let's say you decide to sleep at 10 o'clock at night, maintain that schedule even on the weekends. Another thing is make sure that you have an environment that is conducive for sleep, that it's cooler, the lights are low. This can be very helpful to maintain sleep. On the other hand, make sure too that during the day, there are less opportunities to sleep the whole day. So another thing is structuring activities during the day, making sure that you have exercise, like a physical activity during the day, maybe other activities that includes like maybe hobbies, engagement, listening to music, maybe arts, as Rosa mentioned, very wonderful things to do during the day. If they do nap, make sure that you nap for short periods, 20 minutes, maximum of 30, because this can help reset your sleep schedule too. One thing that we've missed too, that is really a good practice for resetting, is also making sure that when they wake up, one of the first thing that they do is be exposed to the light. So this could mean maybe spending their breakfast or just a few minutes outside where there is sunlight, fresh air. That is going to be really helpful to reset our circadian rhythm too. Another thing is if they're really having difficulty and they're just in their room, make sure you open all the windows and turn on the lights so that it trains your brain to think that this is daytime. So those are just more practical things. And I just realized it's 11 o'clock. So in the interest of time, I think that are useful things that we can do.
Fantastic. Thank you so much. I want to thank everybody for all their fantastic answers. I want to thank everyone for joining us today for this Q&A. Clearly, we could definitely do this again, probably for another hour, because there are a lot of questions that people have to help manage people with advanced Parkinson's as best as possible. So in the interest of time, I know everyone has to get back to what they're meant to be doing. I wanted to thank Lisa, Giselle, Cathi, Rosa, and Tami for giving of your time and your expertise. I want to thank everyone for joining us. And apdaparkinson.org is our website. If you have any additional questions, you can I can put my email address in here. If you have any additional questions, you can feel free to email us. So thank you so much, everybody. Have a wonderful day.
Take care.